Your skin and allergies, coming up next On Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. It protects us from the world around us. Sometimes, though, it reacts by itching, turning red, and swelling. Our skin does so much for us, but when exposed to the wrong plant or insect, can drive us crazy. Dermatology from an allergy perspective. Tonight, On Call with the Prairie Doc.
Hello there, I'm Dr. Tom Luzier, and I'm an allergist from Aberdeen, and I'm your host tonight as Dr. Holm is away, meeting in Pierre. Some of you may remember that Dr. McGran and I filled in for Rick in an episode last year. This time, however, we're turning the tables. I get to interview Dr. McGran about dermatology. He served as a host last session and interviewed me about allergies. We're live here in the Yeager Media Center studio on the campus of South Dakota State University, and welcome your questions about conditions of the skin caused by allergic reactions. You may call us at 1-888-376-6225 or email questions to ask@oncalltv.org. Welcome, Jim.
Well, thanks for bringing us here. This is going to be a fun night.
I am going to enjoy this too. The good Dr. Holm has prepared a walk through the normal anatomy of the skin to help us begin this discussion. So let's take a look.
Hello, let's take a walk around the wonderful cutaneous system, or your skin. Adults are covered with almost 20 square feet of skin tissue, which protects us against infection, invasion, and infestation. Our skin regulates our temperature and allows for nerve reception of vibration, light touch, pain, hot, and cold. So how does our skin work? Let's start at the bottom and work our way up. The base skin area is below the skin, called the subcutaneous tissue, and it's made up of our arteries, veins, and fatty tissue. The next layer is the dermis, which houses our sweat glands, our nerves, lymph vessels, oil glands, and even our hair follicles. The last part of the dermis is the melanocytes, which are responsible for the color that our skin may carry. The next and top layer with which we are most familiar is called the epidermis. This layer is comprised of two types of cells. There are the basal cells, which form the base of our top layer of skin, and our squamous cells on the very top up here. That's what you see when you look at your arm or your face. Now let's look at an example of a malignant melanoma and how it might present. It may present with an ulcer or without an ulcer. It can present in a shallow manner, or it could be deeper. The next picture illustrates a deeper level, and then an even deeper level, and then finally where it goes all the way down through the dermis into the subcutaneous tissue, and the chance of it being spread is greater. Here is an example of a real malignant melanoma, and it carries with it the A, B, C, D, E parts of skin cancer. The A is for asymmetry, it's not perfectly round. The B is that the border is not perfectly sharp. It has fuzzy components. It has a irregular component to it. The C is the color variegated. We have here a lighter area, a red area, a black area, so that you have varying colors, and that gives a clue for malignancy. The D is for a diameter larger than the head of a pencil or the width of a pencil. Pencil is about 7 millimeters. You can mark it off here. The width of this lesion is about 12 millimeters by 20 millimeters. So it's way larger than what it should be. So this gives you some clues about what to look for when we're spotting for cancer, and the beauty and the complexity of the wonderful and amazing skin we're in.
We will answer your questions as they're called in. Should there be more questions than we have time to answer during the broadcast portion of the show, we will continue live streaming on the internet after the show in our after hours portion of our evening. Call us at 1-888-376-6225 or email your questions to oncalltv.org. So we're going to get going here. I'm again Dr. Luzier. This is Dr. McGran. Dr. McGran's of Dakota Dermatology. And we're going to get right into this. We were going to get into some photos of the skin, and we're going to actually address questions about things that you and I see in the office all the time. And we're going to start with your and I's favorite or most frequent or most of the patients show up with this, and this is this one called hives. And this actually, this picture here is the special kind of hives that we've had. Thank you very much. Okay, and I'm going to use the teleprompter here and kind of do some pointing here. Do you find any significance or anything about having these lesions with the little hole in the middle there?
Well, you know, the nice thing about dermatology is before we ask any questions, we look. And so people come in and we're looking at them and they're saying, well, aren't you going to ask me anything? And I say, well, I want to see what's going on first, because once I see what the skin lesion is, then I know the direction I want to go. And in a situation like this, you look at this and say, well, this is a lesion on the skin, but it's actually a process under the skin. And so this leads me right away to a directed area and say, well, how long have you had it? The next question always is, what medications are you taking? And then we get to certain things like, what's your occupation? Where do you live? What do you do? A good number of hives can be related to medications patients are taking. Sometimes it's related to an illness. But something like this, which is a little more serious because you've got these target lesions, will push us hard to get a good history on the patient where we're going. With some hives, you just say, well, you know, this is garden variety hives. Let's see how it goes. But this one, we're going to investigate a little more.
Certainly in my office, I get to see a lot of infectious disease as a cause of the hives. But they rarely cause this target-y type thing unless it's something more of a viral, more of an aggressive type of
I'd agree
virus.
with that. I think a good number of these are virally induced, but there's a couple age groups that will kind of lead me one way or another. That teenager to early college, I like to look for strep infection. I like to look for mycoplasma infection, fairly common in that group. Ladies that are a little older, 50 to 70, I look for urinary tract infections, and some things will do like that. And so there's some times when they'll go with that, but the huge majority are, like you say, they're probably viral.
I've had kind of a run of people who are positive for H. pylori. They have this combination of reflux and heartburn and that kind of thing, which, you know, you don't typically ask that question, but I've had some success in discovering that they have H. pylori, treating it, and having the hives go away.
We're seeing that as well, and you know, when we get, you know, when they come in and they've got an acute urticaria, we don't push too hard, but if they've had it more than 6 weeks, we start asking those important questions, and that's one of the laboratory tests we'll check, especially in people that are that plus 30 age group, and it's not unusual to see that.
I agree 100% with our family practice people when they don't send them to us until they've continue to have the hiving for like more than 3, 4, 5, even 6 weeks?
Exactly. You know, the vast majority of these hives are going to be related to some viral process. They run their course, they go away, and really all we need to do at that point is to give them some relief of the itch and discomfort. So antihistamines, mild baths, things like that can be very effective, and they don't need the $1 million workup.
Very good. Well, we'd like to see a lot of these, so we're going to move ahead here. And I think from my perspective, this is one of the most important things that you do, because this prevents people from dying.
This is the one thing that we as dermatologists deal with, and that is melanoma. And melanoma is one of these conditions that people need to be aware. It's more common, it's coming on more. When I was a medical student, the incidence of melanoma was 1 in 250. The incidence today is about 1 in 50 individuals, and that's pretty scary. You know, 2% of us are going to get this. Melanoma is related to sun exposure, and it seems to be that sunburn plays a role. But the overwhelming thing that's changing now is tanning booths. And there's no question, in the past there was an inference that tanning booths might have a cause or might be related to this. Research today says it is. There's no question about it. Significant exposure to tanning booths is going to definitely increase your risk for melanoma. When we see something like this, what I tell people is, as you saw Rick, he talked about the A, B, C, D, and you know, that sounds okay, but the reality is it's simpler than that. The word is change. If a mole is changing, if you look at it and you're not comfortable, you should have your doctor checking it. Now that doesn't mean you have to see a dermatologist or allergist, but if you've got a family doctor, they are quite capable of looking at it and saying, hey, that's normal or not normal. And if there's something going on there, biopsy is indicated. And in the old days, they'd say, well, you shouldn't do a biopsy if you're going to take a lesion. You should take all of it, not a part of it, because if you do, it might metastasize. That's not true. You can take a biopsy. You're never going to cause metastasis. And the real issue is our biggest mistake is failing to biopsy when you see something atypical.
And of course, we had a little previous discussion, and I said, you know, is it all right if my wife looks at my back?
Absolute best person to be checking you out is the one that knows you best. And what I tell the families to do is, your job as a spouse is to look at that person's back once a month, because if you know what that back looks like today, if it changes, you're the best person to judge that. I'll never criticize somebody coming in and having a normal exam, because now they've got a benchmark. They know what's normal, they know what's not normal, and if that's changing, they come in. And that's how we cure people, is you catch them early, you remove the mole, they're going to be around a long time. You wait too long, then all I can say is, gosh, I wish I would have seen you a year ago.
One of the things that I've seen with melanoma is there's not very much treatment once it gets out of the skin.
You know, our best shot is get it early, get it all. Once it starts to go to a different level, once it's deeper, once it's spread, then you're looking at heroic drugs. And we talk about all these new breakthroughs with melanoma, and there are some breakthroughs, but what they do is they don't cure melanoma, they let you live 10 weeks longer, 10 months longer, a year longer, and these are chemotherapy agents, and they're never fun.
One of the ones that we had talked about is sometimes when you're combing your hair or something like that, you can catch it on something, and so it's kind of important to even look at your scalp. We've had an experience together.
Yes, we both have a patient we've shared that ended up having a mole that they thought was completely benign and ended up being a very dangerous melanoma. And I tell people, you know, if your hairstylist says, hey, there's something funny here, get in and have somebody check that out. That's how we keep these people alive a long time. And you know, the surgery is not that difficult. We can get it out. We don't have to disfigure you. We do it early, you're going to be alive a lot longer. You don't do it, well, gosh, then the insurance guys get to meet you.
All right, very good. Excellent picture of a lesion, irregular size, kind of ulcerating in there. That's a good picture. I get to see this periodically, and I'm in an age group where I don't want this. So you got to tell me a way to keep from getting this?
Well, this is one that Rick and I talked about a couple months back when we were doing something, and that is, what kind of shots do you need to get? You know, there's some things that you can say, well, maybe I'll get this, maybe I won't. there's a shingles shot now, and this is shingles. And the whole issue about this is that shingles isn't just that rash that you get for a week or 2 weeks. Shingles injures the nerves. And if you don't choose to get that shot, you can get shingles. And yeah, we can give you medicine to make the shingles go away, but in many cases the nerves are damaged. And when nerves are damaged, there's pain for weeks, months, and years, and it's a crippling condition. There's really no reason to have that go on. And so the rule of thumb here is, if you're a healthy person, 50 years or older, you should be getting your shingle shot. And the way you do this is you go to your primary doctor, you get a prescription for that shingle shot, you take it to your pharmacist. The pharmacist will mix this up and give you the shot, but you're going to have to make an appointment with the pharmacist because it has to be prepared and given at that moment. Modern day insurance covers this, so there's not a good excuse to say I don't want to do it. There are certain people who are immunosuppressed. They're on certain medications. Their immune system's not up to snuff. What I often tell them, especially like with our psoriasis patients, is before we start you on these drugs that may suppress your immune system, we're going to give you that shingle shot, because once I get that immune system knocked down a little bit, this isn't going to be as effective. So, you know, if you've got something going to go on where you're like with psoriasis or an arthritis and your doctor may be giving you a drug that you're going to be on to control that, it's always a good idea to say, you know, what shot should I get before I start these medicines? And this is one that's really important.
We've seen a lot of shingles in our patients that are immune suppressed for hereditary reasons also. So I think they have a lot of risk in developing this particular disorder. So sometimes it's a flag for me to go and look and see, gee, is there something else going on with their immune system?
One new thing that we're just learning about is, originally when we got this shot, they said, well, this may be a lifetime thing. And now I think the thinking is that, I don't know if it's 10 years or not, but at a certain point they're going to recommend a booster on this.
That's one of the things, because I've had patients come in who have had shingles and they say to me, well, shall I get the shingle shot? The answer is yes, a resounding yes, because even though you have antibody and that kind of thing in these shingles patients, the vaccine seems to protect them from a second episode.
That's good. Yeah, and that's very important.
Well, I know you see a lot of this, and this is as intense an issue of acne, and we see a lot of acne. When should we send acne to you?
Well, you know, I always tell people acne is one of these conditions that we need to treat. And why is that? Well, it may not be so much the appearance as the psychological effect on these kids. And so, you know, your pharmacist is a good place to start. You go to the pharmacy, you say, I've got this acne. He's got some topical medications that you can use, and they work pretty good in a lot of kids. They maybe don't need the dermatologist, but if you've gone that route, you've used the medicine, it's not working, then it's a good idea to get in and see a dermatologist, because acne is a type of thing where not everybody responds to the same medicine, and not every medicine works on everybody, and so you really have to get that specific appropriate care for you, because if you get it, you can turn off this acne, you can prevent the scarring, you can have a normal teenage life. And so I tell people this is one where it's a slam dunk. You know, just because mom or dad had it when they were kids doesn't mean that the young teenagers should suffer through it now. The other point I always make is, just because it's advertised on TV doesn't mean it's the most effective thing out there. That's where I tell people, you know, when you buy that TV product, you're buying that advertising. Go to the pharmacist, ask him about it, because a lot of those products advertised on TV are available as non-prescription products through the pharmacist without any significant cost. And you look at it and say, well, I can get this without it. I don't have to get mail order. I can just talk to my pharmacist.
I noticed that there's a lot of different strengths of medication over the counter, 5%, 10%. Is there a way that a parent or a person can decide what's appropriate?
It's kind of when you look at the individual. If they've got blue eyes, blonde hair, or red hair, and that little, you know, peaches and cream complexion, that's the person you want to, yeah, you want to be a little bit gentle. You don't want to go in there and hit them with the strongest things going. 10% benzoyl peroxide in a lot of people is going to burn. But you can get it in a 2.5%, and that's going to be much more gentle, and it'll provide a lot of benefit. One of the things that you kind of watch out for is that they'll say, you know, let's get this acne wash. Well, these acne washes have salicylic acid, and what they often do is they strip the oils away from the skin, but in many cases that's not appropriate. And acne isn't caused by the oil on your skin, it's caused by inflammation in the hair follicles. So no matter how effectively you strip the oils off the skin, you're not treating acne, you're simply irritating the skin. So really you have to look at the individual. If that kid's got dripping oil on his face, sure, you can go with the 10% product, you can go with the acne washes, but you have to individualize it.
You know, a lot of times in my office we do a lot of food-related illnesses. You know, we see celiac disease and we see milk intolerance. And you know, in the myths of the old days, they used to say, well, if you drink too much milk, you have too much dairy, it has something to do with acne. What's kind of occurred with that ingestion of food and acne?
In my experience, I don't see it very frequently as a cause. Once in a while, kids will come into me and say, you know, every time I eat chocolate, I break out. And I don't know that that really is the cause, but what I do know is that it doesn't hurt to say, okay, well then don't eat 3 chocolate bars. I trained in Wisconsin, and one of the things we did see there is some of these kids would drink whole milk in the dairy. And if you're drinking more than a gallon of whole milk a day, you maybe want to cut back on that. But in the vast majority of people, food doesn't really play a role. Acne is pretty much a hormonal condition, and essentially what happens is that in those early teenage years, there's a male hormone in your system that helps you grow, it helps you produce oil, it helps you have hair. Well, that goes up dramatically in those early teenage years, and when that hormone goes up, it stimulates excessive oil production. The bacteria in the hair follicles takes that oil, breaks it down, releases something called free fatty acids. We got acne. So acne isn't so much what you eat, it's part of that hormonal imbalance that happens in that teenage years.
I noticed on this particular picture that we have these very intense reddening and lifted up, and I know some people kind of pick at those things, and it doesn't seem like that would be a great thing to do.
Absolute bozo no-no. The issue with acne is that scarring occurs primarily when you're picking, digging, doing things like that. The best thing you can do when you've got severe acne is get into your doctor, get appropriate medicine. I often split up the acne treatment into basically 2 elements. All acne starts with plugging. So in many, many cases, we need to use a topical vitamin A to open up those plugged areas, get rid of the blackheads, get rid of the whiteheads. But when you see somebody with this inflammatory acne, they need an anti-inflammatory agent. So they may well need an oral antibiotic for a period of a few months to go in from the inside out and turn that off. They're going to need a topical anti-inflammatory like a benzoyl peroxide or an antibiotic combination. You put those together, you get the inflammation turned off, and then you can back them off this. But if you don't do it, they're going to scar, and that's what we don't want to happen.
Now, I've seen some people who are, at sometimes they talk about getting into the sun and having the sun on your skin, and we just talked about melanoma and trying to avoid the, so what is sunshine and acne? What do they have in common?
I'm one of those moderation guys. Anything in moderation can be a little bit of benefit, and sunlight in some cases is a little bit of benefit, but that's the issue. It's a little bit of benefit. It's never going to be the entire treatment. There's a substantial number of people that get worse in the summer because along with that sunlight, there's heat and humidity, and when you start sweating, that sweat comes out through that same plugged hair follicle and they actually get worse. So that's called acne estivalis. And so you have to take things in moderation. A little bit of sunlight's probably okay. I tell people if you're going to go out and get the mail, you don't need a sunscreen. But if you're going to be out there for more than 20, 30 minutes, sunscreen is vital. You know, what you do today keeps that skin controlled. You don't damage it. You don't get skin cancer. When you're 70, you look like a human being. You don't look like the backside of an elephant going north. That's what you don't want.
So one more question before we get to questions, and that is about Accutane. We see that used, and occasionally I have patients come in, and that seems like a pretty aggressive treatment to me.
Accutane is an aggressive therapy, but it's actually a miracle drug because unfortunately all the tools we have for acne don't work for everyone. And the one tool that works in the vast majority is Accutane. And Accutane is a systemic drug that goes in and pushes the acne out and clears it. And if we give the patient enough of the medicine, we not only clear them, but we can cure them. In the past, there's been a lot of things that Accutane has been blamed on, and they said, well, a significant number of these people get depression, and all the research says probably not. What I find is that there are people that become very emotional. They just seem to be a little more irritable and things like that. And I don't think it's depression, I think it's irritability. The other thing is they'd say, well, this is related to bowel diseases, and the answer is this doesn't cause bowel disease, but if you're predisposed to get bowel disease, it may exacerbate it. So ulcerative colitis, Crohn's disease, not caused by Accutane, but perhaps flare with it. We do treat people with ulcerative colitis and Crohn's disease with Accutane because in many cases, that's our only tool. And we'll do it with the cooperation of the gastroenterologist.
Awesome. Thank you very much. Well, we've got some questions here, and they're very good ones, and we're going to start with our shingles shots. And the question was, does Medicare cover shingles? And I think we just said that
Medicare covers shingles, Medicaid covers shingles. It is mandated by the new Obamacare that shingles is one of the shots that's going to be included in any modern insurance. So literally, if you have insurance, you're going to be covered for the shingle shot. But remember, there are mandates, and so a normal, healthy person isn't eligible for that shot until age 50. But if you have other issues, you're immunosuppressed, or you're going to be immunosuppressed, or like in the case where you'll see people that are genetically immunosuppressed, then there are some options. And I guess that's when I'd throw back to you, because some of your patients don't have a good immune response. Where do we go then?
Well, we've seen with, one, we do an evaluation and see where their immune system is, and can they respond to this viral vaccine without having it spread or something like this. And you know, they attenuate this virus. That means that they make it more, less caustic, if you will, to the patient. So many of them can get this. And I do the same thing. When I'm going to put them on some agent that's immunosuppressive, chemotherapy, something of that order, I encourage my oncologist, I encourage my staff to remind me, be sure they get their shingle shot if they're able to get it. Because once I put them on somebody else's immunity, like gamma globulin, then the shingles vaccine isn't going to work, because the other person's immune system that we're giving them is going to interfere with the response to that shingle shot.
You know, there's another point to come up with. A lot of times people say, well, can I get this shot or can I get that shot? And especially with the flu shot, one of the issues is we talked about attenuated vaccine versus a killed vaccine. And an attenuated vaccine is still a living vaccine. And so if you're immunosuppressed, you shouldn't get that. And with the flu shot, that's that mist that you would get. And so that's not appropriate for someone who is immunosuppressed. And the other shots are probably safe. We're not sure they're always effective, but they're safe.
Right. Killed vaccine is killed.
Yes.
And the attenuated is live stuff, and they've just made it so it won't give you the disease, or will give you a modified disease. Yes. And that kind of leads into this question here about, was told couldn't get the shingle shot because of chemo, and that's because they're so immune suppressed during chemo that they won't be able to get it.
Exactly, and that's why we say get it before you start, because once you're into it, you're more prone to get the shingles recurrence. And a lot of times, you know, remember, shingles is a recurrence of chickenpox. So this is a virus that's already in your system. It typically gets into the various, what they call the geniculate ganglion up in the throat, and sometimes some of the nodal areas in the back. And so it's reactivation of a virus that's already there. So it's key, if you're going to go on these treatments, go on immunosuppressives, talk to your doctor about getting that shot before you start.
Well, there's some excellent questions here, and they kind of run in the same vein. And these are people with lower leg rashes, some of them with mottling, and M-O-T-T-L-E-D, not modeling. And I think it's important here, because one of the points you made was, if this is changing, this should be looked at.
Absolutely. You know, a lot of times systemic disease can be first identified there. You know, we always think of people, if you have heart failure, your legs start to swell. If there's some lung disease, we can sometimes see it in the hands and feet. Some infections will present primarily there. And a lot of times what we see, and very common, especially as you get older, is that, you know, the poorest blood supply is down there in the feet. So where do you dry out first? Well, when the good Lord designed the body, for some reason, he didn't put a lot of oil glands down there. So a huge majority of the people we see have problems with their legs, A, because they're using strong soaps or they're doing something irritating. And a lot of times it doesn't start because you're dry skin, it starts because you're scratching at night. And so it's really important you start with basics. You say, well, use a gentle cleanser, don't use strong soap, use light moisturizers, they're unscented. And if that's not working, you come see us.
Very good. And one of the things that you look at and manage is this: when they accumulate a little fluid in their lower extremity, it seems to aggravate the skin. And
absolutely. And you know, we like to work with our fellow doctors, and especially if somebody has a family doctor or internist already, we'll communicate with them and say, are we using some kind of diuretic? Are you doing things like that? If they don't, then sometimes we'll jump in and do it. But we always want to make sure they're not having active heart failure and that they're not doing that. And you know, the best thing doctors do is we work as teams. And so we try and not be cowboys. We've got compatriots out there, and we communicate with the doctor and get their feeling about it, see where it goes. Sometimes support stockings are appropriate, sometimes diuretics are appropriate, but we have to pay attention to those things.
Very good. The next question was about chicken pox, and since you and I got to actually see a lot of chicken pox, and we don't get to see as much anymore. Yeah. The question was that they came in with a vesicular lesion. The doctor said, you know, this looks like it looks like chicken pox, but it isn't. It's probably just from a cold.
Well, chicken pox has a very particular pattern, and a lot of doctors today wouldn't recognize it because they don't see it. But it is a pox virus, and so this is something that, you know, if you're in Sioux Falls, we can take a little scraping, send it to our laboratory, and they can do special tests and tell us this is a viral thing, it's a pox virus or it's not. Actually, chicken pox can be treated with some of the modern medications, and so we don't generally treat it if it's a mild case. We simply try and isolate the child so they don't infect everyone. But if they're really severe, and in some cases they are, we'll treat with oral medication, and it is effective.
Before we go back, we're going to answer one more question, because this is a good one. If you get shingles once, and are you more or less going to get them over and over?
It's not common to get it more over and over, but you can. And remember, your immune system protects you, and as long as that immune system is intact, you're going to do okay. So often we see people that go through various crises in life, and in that time there's some kind of a blip in their immune system where it's not as effective, and that's when they get a recurrence, especially with cancer patients.
This is such a good question, and it comes to our office often, and this is one that says, is receding nail beds or splitting of the nails a sign of fungus?
Actually, it usually isn't. Generally, it's a sign that you're leaving. We're leaving the Pepsi generation.
Yeah, we are.
What happens is, as we get older, remember, nails are skin. And at a certain level, the skin will stay a nice regular area, but sunlight will thin it out, aging will thin it out. And when you start to look at older people, they start to get these ridges on the nails. Well, that's because they're drying out a little bit. And as I said, nails are skin, and so a little bit of Vaseline on the nails is helpful. So you'll see that. There are diseases that are doing that, but generally speaking, it's not related to anything other than plain old dry skin.
You know, as soon as you said that, I'm looking at my nails and going, oh, you know, maybe a little Vaseline will do it well.
Yeah.
Yes. What about CeraVe? Does that work on that kind of thing?
I love CeraVe. CeraVe is one of these new products that's out there. It's a ceramide-based moisturizer, and it has certain things that I like. It's very effective, it's easy to use, and it's inexpensive. There are other products that have that now, and so Aveeno also has ceramides. We're finding that the Purpose lotion has it, Neutrogena is getting it. Even Eucerin, which is one of our old 1980s favorites, is now starting to add ceramides to their products. And so if you go to your pharmacist and you say, well, what do I need for a lotion? You want a lotion that has a ceramide in it. And ceramide is a real light oil, and the advantage of that product is when you put it on the skin, it absorbs into the skin. And in a number of people, including atopic individuals or people that have atopic eczema, it actually heals their skin. So great product, inexpensive, easy to use, and very elegant too.
Right. We have used a lot of the Cetaphil with the green label, which has the ceramide in it, and kind of as a cleansing agent, so you don't use any soap, and that's been very helpful.
Critical issue. Cleansers, not soaps. Yeah.
Well, we're going to move ahead here, and after that. Well, this is a process that if I see anything like this, I send this to my dermatologic colleagues, because it used to be a lot of steroids, a lot of steroid side effects. This process was not easily taken care of, and now you have a miracle.
Well, this is good old psoriasis. 2% of the population gets it.
Wow.
They used to talk about the heartbreak of psoriasis, and it's really true. But the important thing is, this is a condition that we have a lot of options for. Back when I was a resident, we had 2 options: grease, more grease, and then maybe some ultraviolet light. So there didn't have a lot going on. Now, as the years have gone on, we still use topicals and mild agents, but sometimes that's not enough. Ultraviolet light can work, but it's usually not available. And so we're moving on to oral medications and biologics, and they have literally changed the face of psoriasis, because in the old days when you had psoriasis, you might have looked awful, and people looked at you and said, well, you know, you're kind of a goofy looking person, probably don't want to have a lot to do with you. The other part we didn't understand was the discomfort. People who have psoriasis itch intensely, they're uncomfortable, they're scratching all night long. With modern medication, we can take that away. We can not only clear the skin so they don't look like there's some kind of infected process, they actually can get rid of that itch and discomfort and sleep well and not gross out their spouse with all the flakes all over.
Because this is an immune process that you guys get to take care of, the product that they made actually attacks the underlying increase in this mediator that comes out of all these cells.
Absolutely.
Called TNF alpha, and it's amazing how that works on this particular lesion. The biggest thing for us is, you know, we tried to use antihistamines to control this itch. It's not a histamine itch, so you're not going to get it under control with antihistamines. Doesn't work. And you give them doses and they're asleep with it, you know. And
that's what we did, is we knocked them out, but they were still itching in their sleep.
Absolutely. The other thing, and we kind of talked about this before, is people with psoriasis don't feel good.
Absolutely.
I mean, they have kind of a systemic, I don't feel good, which goes away with these new medications.
You know, and as you were saying, psoriasis, we look at it as a skin disease, but it really isn't. It's a disease of the white blood cells. You inherit the ability to get this disease, and literally what happens, these white blood cells are sending out little signals to the skin, and those signals make the skin grow more rapidly. So literally, psoriasis is skin growing more rapidly because of that faulty protein or signal going out from the white blood cells. So that's what we're doing with these new medications, is we're blocking that signal. If there's no signal going to the skin grows normally, there's no flakes, there's no itch, we've got a happy person.
Is there any risk of cancers or anything like that with this
Well,
disease?
you know, this is one of those things where with every tool there are some negatives, and one of the things about the TNF products is that there's a slight increase in lymphoma, but you got to remember there is an increase in lymphoma with psoriasis by itself. There are some concerns about perhaps some heart disorders, some congestive heart failure, and the theory is that you're suppressing the immune system, so you're going to reduce this individual's ability to fight off disease. The interesting thing from my standpoint is I've used this for about 10 years now, and the vast majority of my patients skate on through. They don't get lymphoma, they don't have heart problems, they don't get infections, they just do well.
Is it your feeling that the lymphoma is maybe something that you're going to get anyway, and it's kind of a background thing?
That's what we don't know. You know, because the incidence of lymphoma without TNF is actually the same as with TNF. And so at that point, we can't say cause and effect.
Right, very good, excellent. Well, it's just great that we have, this process is so intensely itchy. There are not very many things that itch as much as this. I have one that I see a lot, and I see dermatitis herpetiformis. We don't have a picture of that, but that's a wheat-induced disease, and it has that same incredible intensity of itching. I mean, when somebody comes in and says, I don't sleep, I don't feel good, I can't stop itching, and the partner that's with them says they cannot stop itching, whether they're sleeping or not sleeping.
You know, and it's not a rare disease either. And You know, it's fairly easy to diagnose. We do a biopsy, and it's actually an IgA enteropathy. But once you diagnose that, then you're looking at treatment. And unfortunately, the treatment are certain kinds of sulfa drugs, and they're effective, but they can be dangerous. And so we don't have the perfect drug for those at this point.
We're going to dive back into some questions, and this is a good one because it comes to you often. Not on a blood thinner, but my lower arms and hands bruise easily. What would you look at, or what would you look for?
Well, you first of all check things out, and remember aspirin is a blood thinner, and a lot of people don't recognize that, and their doctor says, you know, it would be good for you to take a baby aspirin because that'll reduce your risk for stroke, reduce your risk for heart disease, and so you take the baby aspirin, and probably the most common thing we'll see that will be that. But there are other things that can do it. And so there are diseases where there's purpura, and we talk about something called palpable purpura, and that's usually an infection. But generally that person comes in and they're ill. So they've got something going on, they're running a fever, they're sick. We see that type of thing. A lot of times it can be like what I have. If I were to roll up my arm today, there's a few bruises there, and I call that puppy. I've got a 5-month-old black lab that insists on biting my arm with his little sharp teeth, and I get little bruises all over. The common thing I see is that people go out and do yard work, and they're in and out of their evergreens, and they'll often get little injuries there and get purpura with that. So really history is critical with these.
I noticed too that our skin is thin, and you know, this kind of Germanic, Northern European skin that isn't too great, doesn't have much subcutaneous to it, seems to be quite susceptible to just getting every little bruise and tear, and there isn't much to do about it except the gloves.
And of course, as we get older, it gets thinner. That's just, can't avoid it.
So this is a very good question because you and I will get a kick out of this. Dry burning legs that she self-treated with, one of my favorites, Neosporin. And after the treatment, a concave spot appeared on the leg.
Oh, well, I don't have an answer for the concave spot, but the first advice I always give people is Neosporin's a bozo no-no. Can't use that, and there's a reason why, and that is one of the elements of Neosporin is bacitracin. And there have been rare incidents of people using bacitracin on their legs will have anaphylaxis, and there have been deaths from people using that. So, you know, if you want to use something on the skin, start out with the basics, and that is, number one, itching is not going to be relieved with grease. So if you want to take that itch away, first thing you do is hydrate the skin, and that means get some water on there. Take a cold washcloth, get the skin damp, then you put your moisturizer on. Now, back in the Stone Age when I started practicing, we would use Vaseline, we'd use lard. Crisco was a good one because everybody had it. Nowadays we go back to the CeraVes because they work wonderfully, they're elegant, your pants don't stick to your legs, and it's a great product. So if your legs are burning, the probable answer is your legs are dry. And there's a certain period of time when people get this dry, itchy, burning sensation, and then if they keep going, they don't do anything, they actually get eczema. So there's that period of time before you get eczema where burning is all you'll see. And the way you solve that, hydrate the skin. Get it damp, put a moisturizer on, and keep doing it, because it won't go away in a day. It's going to take you a couple of weeks.
That's terrific advice, and saved me a lot of money. I can just get. So here's a good one, and I may help you with a little of this, and that is, what is the link between irritable bowel syndrome, IBS, it might be inflammatory bowel, and face breakouts, and has been exposed to Agent Orange? When was the last time you heard the Agent Orange?
Oh, that's been a while. You know, this is one, let's be honest, this is your baby. Let's let you jump in.
Well, when I was in the military, which was in the Stone Age in the 70s, Agent Orange had been used extensively on our, to defoliate areas where our troops were fighting. And quite frankly, if you were in a fighting person and you were in a firefight being fired on and you couldn't see who you were shooting at, it was nice to be able to defoliate the area and be able to acquire the enemy. Well, you got doused. If you were a person who handled this agent, you got doused. And so the first things we saw were these pimply rashes of Agent Orange. And because it's a defoliant, they thought, well, it just affects plants, not people. But as time went on, it's been shown that Agent Orange has some diffuse effects on people who are skin. And you know, their skin was open now when they were handling this agent, so they were absorbing some of that chemical. I have not read anything about irritable bowel in a remote exposure to Agent Orange, so I couldn't answer that. That would be one I'd have to look up.
I was kind of on the end of this business with the Agent Orange, and I trained at University of Wisconsin, which turned out to be a big area for Agent Orange because the active ingredient dioxin had been used many, many years before by the farmers. And so actual exposure to dioxin was actually higher in some of the Wisconsin farmers than it was the soldiers. But I did see a lot of the soldiers coming back, and they had something called chloracne, and that is when they were exposed to the Agent Orange, they would develop an acne-like rash on the skin. And when we would see these people, we'd say, well, maybe they don't have this or that, but this is a person that, if there is a consequence of being sprayed with Agent Orange, this is the guy we watch. At University of Wisconsin, where they had studied it, about the only thing that we could really link the Agent Orange or dioxin to was hepatic cancer. And you know, to this day, I haven't seen any substantial studies saying that it causes bowel disease or lymphoma or leukemia. The vast majority of people that I examined coming back from Vietnam didn't have Agent Orange. They had fungal infections, but they thought they had Agent Orange. And so irritable bowel syndrome, I don't know. I haven't heard that. I doubt it.
Okay, very good. I think we have time for maybe one more question. We just have about a minute or so. And so this is a 25-year-old female with acne, and she's asking about long-term effects of antibiotic treatment. I think a little bit about whether you're going to select something out and what do you do.
Well, you know, at age 25, our use of antibiotics is going to be basically a pulse. We'd like to use it, get them clear, and then go on to something else. And so, you know, average individual has acne at something like 14 to maybe 21, 22. And if you're 25 years old and you still have acne, you probably have an inherited problem. And so what we see is that about 5% of adult women have an increased amount of an enzyme in their skin called androstenedione esterase. And this enzyme takes the hormones that are floating around in the skin that are female and corticosteroids and converts them to a male hormone. And we know that if you increase the male hormone, you increase the oil production, the bacteria breaks it down, poof, you got acne. So, long answer to maybe what we wanted, but the issue is if you're an adult person, 25 years of age, the long-term treatment is either going to be a birth control pill, which will suppress that hormone level, or another drug called spironolactone, which also suppresses the hormone. The interesting thing is Accutane in these individuals clears the acne, but it doesn't cure them. So you treat them, you get them clear, a year later they've got the acne back because they still have the androstenedione esterase.
Excellent.
So
Thank you.
see your doctor, your OBGYN, or your dermatologist.
We will be right back after this.
Taste it, crunch it, smack it, love it, break it, dip it, eat it, yum! All these colorful and tasty fruits and veggies are grown right here in South Dakota. When you eat more, you get more. More energy, more vitamins, more minerals, more color, more smiles. So taste it, crunch it, smack it, love it, break it, dip it, eat it, yum! September is Fruit and Veggie Month. Ask for South Dakota grown. More matters.
What kind of skin cancers are there? There are 3 major kinds. In general, 1 in 5 people in the U.S. have had or will have had some kind of skin cancer. In Australia, where the sun is intense, 2 out of 3 skin cancers are basal cell type, 1 in 4 are squamous cell, and 1 in 12 are malignant melanoma. Should I go to a dermatologist for screening? Of course, the dermatologist is the most experienced with skin cancer, but primary care providers can be good at it too. Realize, however, that the first person to find skin cancer should be you, along with a partner to look at over places you cannot see. Screening is especially important for those at high risk for skin cancer. Who's at high risk for skin cancer? At highest risk would be anyone who's had a bad sunburn or excessive lifetime sun exposure, especially when young, and in those with light complexion, freckles, blue eyes, blonde or red-haired. At higher risk for malignant melanoma are those with many moles with a prior personal history of skin cancer and with a family history of malignant melanoma. Does sunscreen help prevent skin cancer? This is widely presumed to be true, but as yet not scientifically proven. And in fact, some speculate that people who use sunscreen could be exposing themselves to more damaging sunlight and also may have more vitamin D deficiency. All that said, it's my opinion there is enough evidence to use sunscreen around here, March through September, and to take 2,000 international units of vitamin D daily. How do I know when to go to the doctor? The ABCDE mnemonic helps us know when a skin lesion might be dangerous. A is asymmetry or irregular shaped. B, border is fuzzy, not sharp. C, more than one color in it. D, diameter wider than a pencil width. And E, lesion evolving or changing. You know, it's common to mistake a benign and safe look-alike seborrheic keratosis for a possible malignant melanoma. Seborrheic keratosis is light brown to black, raised, and waxy. If one can partially peel or scratch off waxy material with the fingernail, then it is benign, while malignant melanomas can be flat with nothing to feel or scratch, or nodular, but never waxy. No question, when you're not sure, see your doctor.
This brings us to the end of our show this evening. Thank you very much. You were, as usual, fantastic, Dr. McGran, and for helping us answer all these questions that we've had. On Call with the Prairie Doc will be preempted next Thursday, September 18th, by a special broadcast of Ken Burns' documentary of the Roosevelts. We'll be recording a new episode of On Call with the Prairie Doc that deals with the Ebola outbreak and other contagious diseases. That show will run on South Dakota Public Broadcasting on Thursday, September 25th. In a test of some of our new technology here at Yeager Media Center, we will be streaming that recording session live on the internet on Tuesday, September 16th at 7 o'clock. Tuesday, September 16th at 7 o'clock Central Time. That's Tuesday. If you would like to view this live, just go on to oncalltv.org and click on the live stream button to watch. As it happens on the show, time's run out. We didn't get to all of your great questions. So to hear our answers to more of those questions, please join us now on our website, oncall.org, where we'll continue live with On Call After Hours on the web in just a few minutes. The great author and humorist Mark Twain had this bit of medical advice. The only way to keep your health is to eat what you don't want, drink what you don't like, and do what you'd rather not. In the words of the absent Dr. Holm, until next time, stay healthy, people. Hello, I'm Dr. Tom Luzier, and welcome to our on-call after hours, where we'll answer some of the questions that we weren't able to get to during our broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you. So we're going to begin right here. We had several questions on rosacea, and I get to see a lot of that in my office also because of the rash portion of the rosacea. And I actually have patients coming in with other problems, and I ask them if they get flushy and that kind of thing.
Well, you know, rosacea is a very common disease, about 15% of the population, and I like to tell people this is multifactorial. There's more than one thing going on here, and you know, perhaps we don't understand completely what's going on, but we know there are certain things, and that is that, number one, rosacea gets worse in the summertime, and the reason that happens is there's a chemical in the skin called cathelicidin, and cathelicidin is there to protect us against infection.
I'm glad you can pronounce that.
I spent
That's
weeks
tough.
learning this, but cathelicidin protects us against staph infection and other bacterial infection, but we only need so much. But sunlight triggers cathelicidin production, and when you increase the cathelicidin, you inflame the blood vessels, you inflame the oil glands, and that's what's happening. So when you look at rosacea, there are basically a couple elements. There's redness because the skin is inflamed. There's inflammation of the oil glands because the pustules are active, and there can be a flushing along with it. And so when we talk about rosacea, we talk about red skin, we talk about pimples on the nose, and we talk about inflammation around the eyes, or blepharitis, because the oil glands of the eyes are involved too. So when we talk about how you're going to treat this, we start out and say, well, what's the primary element? Sometimes it's inflammatory papules, and this is where antibiotics can be helpful. You control it, you don't cure it, you may have to treat it for as long as 5 years, but that can help. If you don't treat it, about 1% of the population can go on to rhinophyma, which is the W.C. Fields nose. And unfortunately, once you get that, about the only thing you can do is come to me and then I blast your nose off with a laser. Not a good plan. The erythema is sometimes helped with antibiotics, but a lot of times what we find is that what we need to do is take away the redness. And so we look at it with a magnifying glass. If you can see blood vessels, lasers are helpful. If it's just flushing, there's a new medicine called Mirvaso that helps with that. So we do have some tools for it. The big issue, I think, in the majority of the people is that inflammation around the eyes, the blepharitis, because if you have blepharitis, your eyes are sore, it's like there's sand in there. That's where antibiotics are pretty helpful. Or you can go with the cyclosporin drops. And we've got a famous lady eye doctor here in Sioux Falls that is on TV telling us about Restasis, which is topical cyclosporin. And that can be helpful, but again, pretty spendy. So rosacea, basically probably triggered by sunlight, exacerbated by things you do on the skin. And so if you're using harsh soaps, strong irritating products, you're going to exacerbate it. So we always start out with basics: gentle cleansers, no soap. Use light moisturizers, no fragrance. That's going to help you. And then you kind of look at it and say, well, how much do we need to do? Some people need a lot of medicine to control it. Some people get away with a little. There are some topical antibiotics that are helpful for some, but a lot of times they just keep you busy.
Now, I've noticed that there are a lot of times on oral antibiotic, particularly the tetracycline group.
Exactly, yep.
And it's worse in the summertime, and that tetracycline is notorious for giving some reactivity. So how do you weigh those two against each other?
Well, you know, that's part of what you may have to look at, is because tetracycline and doxycycline are photosensitizers. And so if the dosage is high enough, you may exacerbate the problem. In other words, make it worse rather than making it better. So it's important to kind of select that out. And the drug that we use often is minocycline, which is one of the tetracycline derivatives that doesn't photosensitize. Awesome. And you can use that at very minuscule doses, so actually below the antibiotic level. So a level of 40 milligrams of minocycline will control it in many people. And that's important because there's a real segment of adult women that get yeast infection with chronic antibiotics.
Very good.
So if we can get that level down, it's a little better.
I have had patients come in who have reddening of the white part of their eyes and have this thing called ocular rosacea. What's that all about?
Well, what happens is we've got these meibomian glands in the eyes. These are oil glands that lubricate the eye. So you not only have water or moisture in your eyes, you have oil that lubricates. And one of the things that happens in rosacea is that there's inflammation in those oil glands, and then you get this little crusty stuff. So it's like you got sandpaper in the eyes. And when the conjunctiva gets irritated, that's what we're going to get.
Right, and of course I end up seeing them because they think they have allergic conjunctivitis.
Exactly,
and
yes.
they've got this kind of dry, irritated eye. And I've seen that when they do get put on the minocycline, that seems to really help that particular form of the rosacea.
Well, and the interesting thing is minocycline is an anti-inflammatory drug, and we always think of it as an antibiotic, but it has a profound anti-inflammatory effect, and so we use minocycline for a number of inflammatory or autoimmune diseases as well as an antibiotic.
Like rheumatoid arthritis
Exactly,
for a while when
yes.
we were using it for that. We were asked about chronic dermatitis and putting a topical, and they have 1% topical cream on that. And the question is how long is that safe, and how do we judge that we're not going to thin the skin and that kind of thing? And
well, one of the issues is this. Steroids are anti-inflammatory, and they're supposed to take away the inflammation, but they don't repair the barrier. So one of the critical things that I teach students is when you come to my office, if you want to repair injured skin, there's two elements. One is take away the inflammation. That's what the steroid does. The second is repair the barrier. That means you're going to have to use something that's lubricating. Creams, lotions, gels are not lubricating. They won't heal it. They'll make it better for 10 days, but as soon as you get there, it's going to come back. If you use an emollient or an ointment, you repair the barrier, and in that case, you can stop the steroid, go on to an emollient, things are going to work out. But that's the failure here, is that in many cases, doctors don't understand there's two elements to healing. Take away the inflammation, repair the barrier. Corticosteroids, even a 1% can injure the skin. What I tend to do is I'm one of these people that likes to use something really strong, heal it, get them off the medication, go on to a moisturizer.
very good, excellent. Just thank you very much for that. Now this next one is about problems in the corners of the mouth, and we see that fairly frequently. It has that goofy name, Perlec.
Perlec, yeah.
Yep.
You know, this is an interesting thing because it's kind of part of our aging phenomenon. As we get older, our skin starts to sag. The collagen gets damaged. It does happen to me. But as we get older, this skin starts to sag a little bit, and we develop a crease. And we have yeast in our mouth naturally. And so what happens is you start to colonize this area with a little bit of yeast. And so this is one of those things where sometimes an antibiotic will help it, but more often an anti-yeast medicine will help. But again, it's the same kind of an issue. Remember, there's an injury and there needs to be a repair. So the anti-yeast medicine takes away the yeast, but then you need to repair that skin.
Do you do that topically or do that orally?
I usually do it topically. I'll use a mild monostat or ketoconazole type of anti-yeast medicine.
Does it help
for
to
just a
rinse your
couple
mouth
days?
with
Probably
nystatin
don't even need to do that.
Okay.
I don't use nystatin for one reason, and that's cost.
Okay.
It works, it's expensive, but I always turn back around and say, okay, now that you've got this healed, you need to use a little lip balm there, create a little barrier, because when the skin gets injured, it's going to come back.
Do you think those waxy lymph balms work just as good as emollients and ointments?
Well, and here's the issue. Paraffin or wax type products will stay longer. Ointments, particularly, which are Vaseline-like base, they don't stay very long. So actually, if you want to get protection on the lips, you got to use a paraffin or wax-based product, which is the lip balms.
Now, is there any problem if those lip balms have flavoring in them?
Absolutely,
and all kind of stuff
absolutely.
Like that?
Simple is better. You know, if you can get something fairly simple, you know, when it's got 12 flavors and all the good scents and tastes like, say, raspberry, remember those are potential allergens. And a number of the products that used to have cinnamon were really great for us because that cinnamic aldehyde, which is the cinnamon flavor, causes a lot of allergies. So you'll see that. Lipstick contains eosinophil. Some people get allergic to the eosin. So the best answer is if you can get just a basic one, that's fine. There's some of these that have beeswax in it that you can buy, and they're actually pretty good.
Excellent. Thank you. Well, this is pimples on the tops of the hands, and what are the common causes of that? And we know there's a lot of them, but whenever we have pimples on the tops of the hands and routine stuff like harsh, they're usually washing their hands a lot, really beating their skin up. But once we get past that, I usually send them to you.
Well, you hit it right on the head, because most of the time intact normal skin is not going to have this. So what do? Well, soaps, detergent, cleaning agents, you've injured the skin and you've set it up for that. Once in a while it's a staph infection, maybe some other things, and so we kind of look at that, but we start with the basics. What are you doing? What's going on? Why are you getting
hands
this?
take quite a beating under
Yep.
those. We have a couple questions about adult acne or whiteheads on the face in elderly patients. Is that a different process?
That's absolutely a different process, and we call those comedones and cysts of Favre and Roquechot, who are two French dermatologists. And essentially what happens is that as we age, there can be some photo damage that literally leads us to get these little whiteheads and little pustule type things. That's an aging phenomenon. It's not true acne. It's a plugging phenomenon from chronic sunlight.
So people in England who never see the sun don't get as
Probably
much of
don't
this
get
as
it.
we
Very
have
common.
here.
It'd be common in the French and southern France. What we do with it, topical vitamin A can help, and sometimes an aggressive dermatology nurse will get in there and help you tease out some of those.
Oh, excellent. Thank you. We were asking about psoriasis, and we have a couple questions still, and one of them was about gluten and psoriasis. Have you seen much with that's substantial that says that those two, that TNF-alpha, that the neutrophils are affected by gluten?
We don't see psoriasis affecting the gluten, but what we do see is one of the diseases you see a lot, and that's dermatitis herpetiformis. And that is very much related to the gluten type things, and you can jump in on that.
Well, I think the great thing about it is it used to be a pretty hard diagnosis, except for the itching. The itching was so intense that you just were impressed by their itching. But when they come to your office, they get a biopsy. And then they send it to the dermatologic pathologist. And that guy makes the diagnosis because he stains that, and it is jump off the screen. That's what it is, no doubt about it, and the wheat, avoiding wheat. And if they come to me and say, well, I still have the rash, I know they're not avoiding wheat.
Absolutely, yeah. We, back in the old days when I started, we'd give them Dapsone, we'd give them these sulfa drugs, and you could suppress it. But we didn't really pay a lot of attention to diet, and nowadays we know that if you're not dealing with the diet, if you're not going to a gluten-free diet, you're not going to be successful. And dietitians have done such a spectacular job of putting out gluten-free diets in this day and age that we really limit the amount of medication we're using now. If you're on a gluten-free diet and you've got dermatitis herpetiformis, you can probably go drug-free if you just stay with that gluten-free diet.
Very good. Thank you very much. They ask if diet ever has anything to do with seborrhea. So first thing, tell people what seborrhea is compared to psoriasis and eczema and these other common skin things.
Seborrhea is when you get that little waxy red rash that's kind of along through here, sometimes goes up here. It'll occasionally get down into this area, and really severe, it'll go right into the ears, into the hairline, and some of us guys, it'll be on the chest and even on the back. It's one of those things where we know a little bit about it, we don't know a lot about it, and the reason is because it's such a simple process that when you put a little topical steroid on, it goes away. And because it goes away, we're not going to do any research. So what we can tell you is that there are some little microorganisms in the skin that seem to, when they increase, the seborrheic dermatitis gets worse. So if you use like a ketoconazole shampoo, you can reduce that, and that helps it sometimes. And I actually have some people use the old Nizoral shampoo as a facial wash, because that'll help. But more often than not, a simple 1% hydrocortisone once in a while controls it very well.
Very good. Thank you very much. Well, this is a tough question, and we may just be able to say, we don't know the answer, but does the melanoma affect the nervous system in a way that you might know that you've got it?
Melanoma typically goes through the lymphatics, and so routinely I'd say no. It doesn't normally affect the nerve system.
Right. I think you have to do that skin inspection because you're not going to know. So you just have to have somebody go over your skin. And,
Exactly.
We don't look under our arms very often, and we definitely don't look at the back end of us very often at all. And you just need to bite the pride and have somebody
Get
take
somebody
a look.
looking at it. Yep.
Exactly. Well, this is a very good question that she's talking about post-herpetic neuralgia, and this is why we get the shingle shot.
Absolutely.
This is the damage you talked about in the nerves, and I think it's hard to deal with. We have pain management people that have to help these people out. These are our physician colleagues. They have to leave our office and go over there because they have to get injections, these nerve slowing agents like Neurontin, things like that.
Exactly. You know, shingles is a process that migrates the virus migrates down the nerves, and when that happens, the body's immune system seems to destroy the sheath surrounding the nerves, and that produces this chronic pain. And when we go in and kill the virus, we're not necessarily preventing that damage. So when that damage occurs, the virus is gone, everything is healing, well, we're still in pain. We've still got this because we've injured those nerves, and it goes on forever. There have been some studies early on that suggested steroids could help prevent this, and I'm a little bit up and down on that. If a patient comes in and they have a lot of discomfort when they have shingles, I'll give them a burst of steroids, and I hope that it's going to help, but I don't really know. When they get to where they come in and it's gone and they've still got the pain, we're going to start them on medicines that depress the sensation, like doxepin. We'll use the Neurontin you talk about, do the shots. If I can, I like to get them into a pain specialist, and that's the best answer when you can. Sometimes they say, well, you're going to do it, and then I try and help them, but realistically, I'm not the expert, and referral is probably the best answer there.
I have very mixed reviews also on the use of Valtrex, which is an antiviral, or acyclovir, which is the original drug. And I think if they come in early, I think it has some benefit because I think the virus is available.
Yep.
And I think after a week of having the shingles, you've probably exhausted the viral part.
Pretty iffy about what benefits are going to be. The issue with shingles is you got to hit them hard, you got to hit them early, and if you're out there a week or two, the cow's out of the barn is out, you're probably not going to prevent it.
Okay, so our last question is one, and you had touched on this, and I would like you to talk a little bit about since I'm an immune guy, I like to hear about the immunity associated with the alopecia that we talked about earlier.
Well, what I tell people is we always start out with alopecia and we kind of go through a pattern. And so the first thing I look at is, where is it? Is it annular plaques? Is it widespread? Is it diffuse? You know, a good number of people have hair loss because it's genetic. Some people will have hair loss because of diseases like lupus and dermatitis retiformis, lichen planus.
So inflammatory kinds of skin, any kind of inflammation.
So I want to rule that out first. Then if somebody comes in, they have like patchy type hair loss, we don't leap right into alopecia areata, which is where we're going with this, but there are people that can have other things. And so one of the things I'll look at is I'll examine it with a magnification and I'll touch it, because there are cases where they can have tumors in the scalp. And the classic one is breast cancer metastasizing to the scalp, which looks just like alopecia areata. But if you touch it and you look at it, with alopecia areata, there are going to be a few little hair follicles, little question mark hairs there. And with the breast cancer, there's nothing. And so that's where one of the steps is, if you're not sure, get a biopsy and get a history, because if they've had something like that, you want to check it. Alopecia areata is one of these really interesting diseases that we don't understand very well. We call it an autoimmune disease because literally the body is attacking the hair follicles. And to the best of our knowledge, what it's doing is not destroying the hair follicle, but inactivating the hair to where it quits growing. So theoretically, even if your hair has been gone for 20 years, it can possibly come back. It traditionally doesn't, but it's possible. And what's going on is there are little lymphocytes surrounding these hair follicles, and they send out little signals that are the immune suppressors that shut this down. And so what do we do if it's mild? Well, we'll give them topical steroids to try and work on it. We'll intralegally inject it. In rare cases, we'll go with oral medicines, but oral medicines are a honeymoon. You can only use them for so long, and then we're done. Now, what you and I were talking about is that there are new medicines coming along that are going to be dramatically effective. And so what we don't know yet is how safe they are, how long-term effective they're going to be, how much do they cost, but we're going to be looking at some good things in the future.
Awesome. So one last question, and this is one that I want you to field with telling us a little bit about sometimes things are so complex that you really have to work through each step because there's 10 or 15 appropriate steps, just like we had just talked about alopecia.
Well, and that's our patient from Astoria, and she writes in and she says, I've had some hair loss, particularly in the eyebrows. I've seen a dermatologist. They've checked me for a number of different diseases. What do I have? Well, I'd love to say that you know, Karnak can give you an answer over the TV. This is one that requires a workup. We start out with some basics, and you know, what things can cause hair loss? Well, simple dermatitis can cause hair loss. Allergy to products you use can cause hair loss. Hypothyroid conditions, you've checked that, that can cause it. Poisons can cause it. There are autoimmune diseases like alopecia areata. So really what we need to do is sit down and in a systematic fashion identify, first of all, what is the pattern? Where is it at? Is it somewhere else? Is there something else going on? And if there is, where do you go? And then what's the appropriate treatment? And sometimes we don't have a good answer. Unfortunately, there are certain people that as we get older, you just lose the lateral part of the eyebrows, and that's not a disease. It's called aging. So we'd really have to examine you to know.
Do you know on biopsy about, does that help us at all?
In some cases we do. What I like to not do is to do biopsies that are going to be scarring, and so we'll try and find spots where we can kind of hide it so it won't show, and we'll take a tiny biopsy. But sometimes you have to have that to get an answer.
Right. Very good. Thank you very much, and thank you for joining us on our website. We appreciate all of your questions, and we appreciate the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at our regular time and call in or email your questions. Then watch for our columns in your local newspaper. Listen to our On-Call Conversations radio show on the station near you. And until next time, stay healthy, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dr. Mark Bubach and Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera,
Brookings Health System,
and Fishback Financial Corporation.